Hey, deserving listeners, as a part of continuing the spring cleaning, in which I will finally get to all of your emails that you've been sending in over the last number of months, I thought I would continue doing that right now. And a lot of these emails are pretty technical, geared towards therapists. So if that will bore you, you might want to skip this episode. This first email is from annual patron Megan from Arizona. She says, "Hi, Dr. Hunter." I'll just summarize what she's saying in this email. She sent me an article, a journal article, about evidence-based therapy and CBT, and it's critical of it. So I thought I would read that article and talk about it here. So the article is written by Jonathan Shedler, published in 2018, titled, "Where is the Evidence for Evidence-Based Therapy?" So just reading one of the introductory paragraphs here. "Behind the evidence-based therapy movement lies a master narrative that increasingly dominates the mental health landscape. The master narrative goes something like this. In the Dark Ages, therapists practiced unproven, unscientific therapy. Evidence-based therapies are scientifically proven and superior. That master narrative has become a justification for all-out attacks on traditional talk therapy. That is therapy aimed at fostering self-examination and self-understanding in the context of an ongoing, meaningful therapy relationship." Just chiming in here. Yeah, absolutely. There will be people that will say that humanistic therapies and Freudian therapies are complete hogwash and are a thing of the past, like when medical doctors used to bleed people to try to cure certain ailments, right? So that is the narrative, and I've heard people say that. The facts are that, and I don't know what the rest he gets into in this article, the fact is that there is a lot of evidence that quote-unquote Freudian types of therapies or psychodynamic, relational, psychoanalytic therapies, and certainly humanistic therapies, there's a ton of evidence, mountains and mountains of evidence that demonstrate that these forms of therapy do work for certain conditions. If, for example, you have a phobia, then Freudian therapies do not work, and humanistic therapies aren't necessarily going to work. If you have a phobia, you want to use exposure therapy, which is a form of behavioral therapy. So with phobias, you want to use that. But if someone comes in after a major breakup, like a divorce, or they just got dumped by their long-term partner and they're sad about it, then behaviorism, the exposure therapy is not indicated for that presentation and therapy. And in that presentation, humanistic therapies are definitely shown through evidence, thousands of studies showing that it is helpful in that situation. And by humanistic, I mean reflective listening, compassion, self-exploration, being in the here and now, allowing someone to get in touch with their needs, emotional expression, experiences that are meaningful to finding meaning in one's life, existential therapies, that kind of thing. So for sure. And if that individual complains that they've had a half a dozen or a dozen relationships that all seem to end the same and tend to be with the same sort of person, then psychodynamic-oriented therapies, interpersonal therapies, insight-oriented therapies evidence shows that they do help. Transference-based therapies definitely do help. So personality disorders, for example, with borderline being one personality disorder, it has been shown through evidence, through empirical research. These are sound studies. These are not just dubious studies by dubious researchers, have found that transference-based therapies or relationship-based therapies between therapist and client do show positive long-term outcomes. There are two reasons why in my field you will hear therapists say that CBT is basically the only form of therapy that works. One is because, there are a lot of reasons why that come to mind. One is that CBT is much easier to understand than the other forms of therapy, especially if you're a very concrete-minded individual. And there are very concrete-minded therapists out there, believe me. And so for them, CBT is very easy for them to understand. I'm not saying that these people are stupid or anything. I'm just saying that therapy is very complicated. Humanistic therapies, psychodynamic therapies are extremely complicated. You can spend your entire career studying these things and basically only halfway understand them. Systemic therapies, family systems therapies are very hard to understand really at its core. People act like they get it, but my experience is, for myself, for example, I had to teach these things for basically 15 plus years before I really started to get it. So because of this reason, you have a lot of people that enter graduate school and they get exposed to a few different theories, and they just gravitate towards CBT because it reduces their anxiety about learning about the field. And they have a disdain for certain kinds of theories, certain kinds of therapies that are confusing to them. And so as a way of expressing that frustration with the confusion, they'll just say it's discountable. I've heard people say like everything that Freud ever said was ridiculous. And that is a ridiculous statement because Freud said a lot of things. Yes, some of the things he said in today's light, we see them as being a little ridiculous. But he said a lot of things that we operate from as if it's just a known truth. The fact that we have a personality, the fact that talk therapy even works, Freud basically invented. There are people before him that kind of introduced the idea, but not in the way that he did, and certainly not in the way that he proliferated through Western culture. And we have him to thank for a lot of different things. Does it mean that you have to be Freudian? No. Does it mean that it's stupid if you specialize in CBT? No, absolutely not. But to denigrate other forms of therapy and to claim that they're not evidence-based is just factually wrong. It's just scientifically wrong statement to say that there's no evidence that humanistic or psychodynamic therapies work. And I could yammer about this forever, but I'll stop after just saying this final point, which is that there is a culture that just gets perpetuated in our field. If you, as a trainee, as a psychology student, as a psychotherapy student, go to a program that for whatever reason is just dominated by professors that adhere to the false notion that CBT is the only form of therapy, then you're going to get a lot of propaganda for CBT and a lot of propaganda against the other kinds of therapy. So you will emerge from graduate school basically having been brainwashed. You've been brainwashed by people that don't know what they're talking about, or they were taught by people who were brainwashed as well, and the cycle just continues. But really, okay, let me just continue talking a little bit because I think this will apply to everyone. To be clear, some people they'll email into me and they'll be like, yeah, Kirk, I know you hate CBT. I do not hate CBT. I want to be clear. I love CBT. I love all forms of therapy. I just don't believe that CBT is the only form of therapy. You know, there's a wide variety of wonderful therapies that I adhere to in every session. I adhere to feminist theory. I adhere to systemic theory. I adhere to humanistic ideas, and that's a very broad topic. I adhere to existential ideas, experiential ideas, psychodynamic ideas, relational therapy ideas, interpersonal, intersubjective. I adhere to structural and strategic and gestalt. And I mean, it's all great, including behaviorism and cognitivism. These things are very important ideas to understand. They're pretty universally understood. I mean, everyone basically adheres to the idea that your perspective does matter, right? If you look at things in a negative way, then you're going to feel negative about it. And if you look at it in a positive way, you're going to feel positive about it. It's well understood. Everyone gets that. Also, if you do things by habit that cause you problems, breaking out of that habit is important. That's another, pillar in the behaviorism idea of therapy. I'm simplifying it, of course. But so I want to be clear. I love cognitive therapy. I love behavioral therapy. I use it all the time. I just don't think it's the only thing. And when as a therapist, if I were to exclude those other schools of thought, I would definitely be not serving my clients well. And I see other therapists doing this sometimes. And another thing, I find that a lot of lay people will like CBT, I think partially because it's easier to understand, but also because it inadvertently plays into a lot of our cultural notions of anti-emotion. CBT is, depending on how, the thing is to call yourself a CBT therapist can mean a wide variety of things. It could mean that you are very pragmatic and very brief, meaning that you only want to treat people for 5 to 10 sessions total. But I know other CBT therapists that are not like that. They're much more likely to create space for emotion and this sort of thing. So I don't want to paint it as if it's a monolith. But when you describe CBT to the lay public, for some people, it appeals to them, I think, because it appeals to common notions in our society that downplay emotions. Our society already is terrified of emotions and shames emotions, and CBT plays into that. CBT does not shame emotions, but CBT doesn't emphasize them. And CBT will say that your emotions, that it kind of depends on how you take it, but CBT could be interpreted as a form of therapy that basically says your emotions are a bit of a nuisance. Not every CBT therapist would operate that way, but it can look that way to some therapists and to some lay people. Whereas when you talk about psychodynamic theory or humanistic theory, you cannot avoid emotions. These forms of therapy are very focused on emotions, usually. And again, I can't paint it as a monolith, those as a monolith either. But these theories are much more long-term. They tend to be much more interested in self-reflection, much more validation, much more expression of emotion. And because our society hates emotion, then our society hates those forms of therapy. That's just an opinion, of course, but I think that it's true. And because we live in a society that is sexist and misogynistic, and we have been for quite some time, one could consider CBT to be more manly and the other forms of therapy to be more womanly. That with CBT, it's much more pragmatic, and you got to pull yourself up by your bootstraps, and you have to get back out there and make it happen. And we don't want to wallow in telling stories and talking about emotions and expressing emotions. You've got to do a job here. Again, not every CBT therapist is like this, but it can be at least seen that way. Whereas the other forms of therapy could be thought of as this weak endeavor of indulging yourself in feminine, problematic emotions. And of course, that's not what it is, but I think that's another influence. All right, a 16 mail is from anonymous patron. She writes, I'm a first-year student in a CFT graduate program. CFT stands for Couple and Family Therapy. I've been watching and listening to your podcast for 2 years now, and I'm a huge fan. My boyfriend and I watch your videos as a couple, and we find them super helpful. Just chiming in here. Yeah, I love it when I hear about couples watching my videos, because I just imagine that my reaction videos, when couples are watching them, it prompts conversations or at least thoughts about their own relationship with the person they're sitting next to, because that show will the shows that I react to highlight relationship dynamics and misunderstandings that people have. And I just imagine that it would be fun to watch reality TV while this therapist watched, but also I can imagine it being useful in prompting conversations going on here. In fact, your podcast is the reason why I decided to pursue a marriage and family therapy degree. Just jamming in here. Yeah, when I hear that, I am just so overjoyed to hear that I could be the catalyst for someone entering the field and having a rich, wonderful life as a helper, as a person who is out there at the ground level helping people. It's just really great to hear. We need more therapists in the world going on here. I wanted to reach out because I've had a bit of confusion around my degree and license, and I was wondering if you could clear some things up for me. Being that I've watched your videos for the past 2 years, and I've been heavily influenced by your views and practices when it comes to therapy models, theories of change, etc. And when I entered my program, I incorrectly expected my professors to reflect what you spoke about in your videos. While the systemic portion of what you talk about is in the marriage and family therapy program that I'm in, most of my program has a less diagnostic approach, and their theories for change seem like it's about spinning things in the most positive light. Just chiming in here. Yeah, so maybe I should say this occasionally, that if you have a very similar point of view, that similar to me and Bob, following in my footsteps, career-wise and training-wise, won't necessarily lead you into programs that will have my point of view. In fact, my point of view is unique in psychology, but also specifically in marriage and family therapy. For example, in my program, as far as I know, last I knew, maybe they have some new professors now that I don't know of, and I don't know their specialty, but I was one of the only, if not the only professor in my marriage and family therapy program that had any sort of working knowledge of psychodynamic therapies, of object relations, and that and people would reach out to me. Sometimes professors would even have me guest lecture when the chapter or the module came up in their class about say, object relations therapy, they would actually have me come in and teach that section because they just didn't feel competent enough to do so, because it's pretty complicated. So it doesn't surprise me that you are in a program, whether it's MFT or otherwise, that has a much different point of view, and that there might not be a single professor that talks about the things that I talk about. So, I like I said earlier in this episode, I think we're heading kind of in a bad direction overall as a field. I don't want to be a doomsday seer, but it kind of feels that way to me. At the very least, I think it'll be very hard for clients to find a good enough therapist, and I think hard for trainees to be trained well with the kind of philosophies and the kinds of therapies that have really got our field into the public awareness. I mean, the fact that people know what talk therapy is because of Freudian therapies and humanistic therapies. There's a reason why people loved those things in the past, therapists and clients included, and I feel like it's all just being pushed aside. But anyway, that makes me sad that you feel... The other thing that you're saying here, Anonymous Patron, is that the systemic portion is there, but you're saying most of the program has a less diagnostic approach. And just chiming in here, most family therapists do not emphasize personality or diagnosis, or sometimes they'll literally just eschew it altogether. They will reject the notion that there are personalities and that there are diagnoses. They'll just say, well, we have to live in that system because we have to bill insurance, but we're not going to believe those things. We don't think that those things are real. And I understand the foundation of their argument, and I've had similar kinds of ideas in my head as well, but to just throw it all out is, I think, ignoring the reality of humans and also ignoring an opportunity to help people in a variety of ways. So there's that. But also, you also say here that you seem to be getting this notion that your professors are teaching a form of therapy that seems to be just spinning things in a more positive light. Yeah, that is what CBT can be reduced to. CBT is, when it's done right, it's pretty great. But a lot of people, because they don't understand what it is, they will interpret CBT, and even within a family therapy program, which you're in, which isn't traditionally supposed to adhere to CBT, but I feel like it's becoming more and more part of it. Plus, there are schools of thought within family therapy, like structural family, reframes, this kind of thing, if you're in the know about those terms, that they will just interpret that. A lot of people, professors and students, will just interpret all that stuff is great. Reframes are great. Thinking positive is great. But if you only focus on that, they basically just reduce all of talk therapy to that. And you go to therapy, and some of you might have had this experience. You go to therapy, and your therapist basically just tries to convince you to think more positively, and that's basically all that they do. They're just like, well, is there another way of looking at that? Or, maybe you shouldn't think that way, And if it was that easy, then all we'd have to do is just give someone a pamphlet and say, don't go to therapy, just think positively. And the pamphlet would be 1 page long with just like 15 words on it. If it was that simple, then wow, right? And of course, things aren't that simple. Even cognitive behavioral therapy isn't that simple. But yeah, I've seen this before as well. Basically, you have the blind leading the blind. You have professors who were trained poorly, and they're poorly training their students as well. I've seen it before going on here. I feel that I am not learning about why people do things, but from your content, I find the why, you answer the question why people do things, to be very important for understanding and enacting change. Just chiming in here. Yeah, completely agree. When you understand why people are doing something, it definitely gives you a direction with therapy, right? And that can be very varied. And of course, we can never know exactly why people are doing things, but if we have a conceptualization, it can help for sure. Going on, I am wondering if you could provide some resources, books or podcasts from someone in my position, any words of encouragement. Also, I am curious to know what informs your practice. What are the models that you follow? I am thinking of pursuing a doctorate, but I am undecided on whether I want to continue pursuing a doctorate in MFT or if I want to get a PsyD. end of email. Yeah, so the first thing I'll answer is resources. I'm terrible about keeping track of resources. So I don't have any resources to offer you, and I apologize for that. People ask me for and it just seems like the sort of thing that I should have on hand, that I would have podcasts or books or training programs or something. But I don't know, there's just something about me that makes it hard for me to notice that or retain it or jot it down or something. I just don't have anything for you, and I apologize for that. Also, but I get it that you're like, my program doesn't seem to be giving me what I want. What I'll say to that is, so when I got my master's degree in marriage and family therapy, everything I was learning was new to me. And so everything was mind-blowing to me. I was a 24-year-old dirtbag who knew nothing about anything, and everything was mind-blowing. And it was just so eye-opening. In the 2 years I was in graduate school getting my master's, I was totally transformed. When I went back to school 10 years later to get my doctorate, I had already been a professor. Actually, it was 13 years later. And I was a professor, I was a podcaster, and I knew a lot more. So when I was in my doctorate program, which involved another master's and a doctorate, I would be in class learning about things or being taught things that I already knew. In fact, there were some times when I was being taught by professors that knew far less than I did about the topic they were talking about. And that's just natural. I was already practicing, I was a professor myself, and sometimes I'm just, particularly in the areas of psychotherapy, the psychotherapy courses I took were extremely rudimentary and actually extremely boring to me. I mean, it was just like really hard for me to get through those courses because I'm just like, I've been practicing for 14, 15, 16 years, and I've been a professor. I teach this stuff. And even if the professor did the class well, it would still be boring to me. Now, there were classes in my doctorate that were mind-blowing. Things like forensic psychology, statistics, research, those kinds of things I hadn't had really any instruction on. So that was interesting. And it helped me to fine-tune my writing skills and also my teaching skills, because I would observe the teachers as they're teaching a class, and I'd be like, okay, I like that, I don't like that, I like that, I don't like that. And it helped me to refine my own teaching skills. But it was hard to always feel motivated to go to graduate school because of this reason, because some of the classes felt kind of worthless to me. So what I did was I just made it useful to me. For example, there was this one course, and I won't go into details as to how stupid it was, but it was a good subject, but it was the class was structured in a very, let's just say, boring way to me. And I wasn't going to learn anything if I just went through the motions. And so what I decided to do is, when it came time to work on a project, because we all had to work on a project, I decided to lean into that project heavily, even though I was pretty sure that the professor didn't care. Like, I was pretty sure the professor was just going to, kind of skim through my paper or something and consider it like, yeah, it's fine. And then she would just pass me. But instead, what I did is I'm like, okay, I'm going to really dedicate myself. I'm going to make use of this class in the way that I want to. So for you, anonymous patron, that might be my suggestion is, undoubtedly there are some things in the class that you're learning, but you can maybe really lean into it and say, okay, well, for my project in this class, I'm going to go in a direction that the professor isn't necessarily offering to me. And I'll ask them, is it okay if I go down this road? But I'm going to make this useful to me. The other thing you can do is, after hours, or maybe even in class, just ask your professor some of these questions. Just say, hey, I don't know, but it kind of seems like the main intervention that you're recommending, in my words, it just seems like you want me to spin things in a more positive light, but I could be wrong. So could we talk about that? Because family therapy is extremely complicated, and there's a lot of avenues, there's a lot of depth, there's a lot of corners to it that often don't get talked about. The other thing is that you say, I'm curious as to what informs your practice. What models do I follow? Well, to answer that question, I think I already did earlier, everything informs my practice. I'm of the belief, and research demonstrates this, there's important research by John Norcross that demonstrates that therapists who incorporate a wide variety of therapies into their practice and tailor the treatment to the client instead of the other way around have very positive outcomes with clients. For example, if a client comes in talking about a phobia, then I use behaviorism with that client. I don't just shoehorn my particular approach to them. I figure out what's wrong, and then I utilize something in my repertoire to use with that client. If another client comes in and they have borderline, then I'm not going to just use behaviorism, right? I'm going to use a variety of other things. I'm going to use transference-based, mentalization-based, attachment-based therapies, emotional regulation, which you could argue is a CBT thing. I'm going to use humanistic therapies to make the client feel safe and comfortable and heard and understood. And I will utilize those therapies when needed, and I'll make the judgment. The problem with that is that to know the theories well enough to use them in therapy, it can take you literally decades of study. I mean, it has taken me, I would say that it was probably 15 years into my career as a professor and as a therapist before I basically grasped the different theories of therapy before I could actually use them. And before that point, I was kind of focusing on a few different theories. So that's one thing to do, is to focus on a few different theories in the beginning and then slowly start to acquire competence in these other theories. The other thing is graduate school is not where you learn most of what you will know. People think there's this notion in society that somehow you go to graduate school and it teaches you everything, and then you're ready to practice, you're ready to be whatever it is that they're trying to train you to be. No joke. I would say about 1% of what I know about therapy and human beings and how to be a therapist and how to be a human being myself, but particularly how to be a therapist, 1% of that was from graduate school. And I have, let's 1, 2, 3, 4, 5, 6, 7, I don't know. I have like 8, 9 years of graduate school, intensive graduate school. And about 1% of what I know about how to help people in the office of psychotherapy was acquired in those graduate school experiences. Maybe it's a little bit more than 1%, but probably not much, especially if I just absorbed what the professors were telling me and didn't extend myself into the subject so that I could go deeper myself. If I just relied on professors to teach me as if I was this passive sponge of information, certainly it would be even less than 1%. So that's one thing to do. But yeah, I follow all the models because they're all good. All the models that are evidence-based, and there are several, all the ones that I've mentioned, all the important ones going on here. I'm thinking of pursuing a doctorate. All right, so you ask about, you're just like, I don't know if this is where it's coming from, an honest patron. You're like, I don't like my current program, and I feel like I'm not learning a lot. So is it that I should just do what Kirk did, which is also go back and get a PsyD? Is that where he got the way that he is? And the answer to that, as I said earlier, is no. So if you want to get a PsyD, that's fine, but it would be unfortunate because the PsyD does not recognize your MFT. I won't go into weeds on that, but you'd basically be starting over as if you didn't have any education in your master's program. I mean, maybe some of the courses would be transferred over, but maybe not. And at most, it would just be like a few courses usually. Anyway, so it's not true. I mean, psychology programs, training you to be a psychologist can be even worse in this respect. So not always, and it's just anecdotal in my experience. But if you really want to learn the things that we talk about in this podcast, you need to find a mentor and a supervisor like that knows these things and can walk you through it. And that person might be in your program, they might be outside your program. So you want to find a supervisor, and you could go to AAMFT, the Marriage and Family Therapy Association, and search for supervisors. And you can literally just ask them a few questions. What do you think about attachment-based therapies? What do you think, how would you describe family therapy or something? Or in my program, it seems like all they want us to do is to spin things in a positive light. What do you think about that? And then you would gauge the response from a supervisor, because I'm guessing that, I don't know, 1 out of 10 supervisors would respond in a way that would inspire you to want to work under them. And so you'd want to hire that person or befriend them or something. All right, let's take a break. We'll get back, more emails. All right, we're back from the break. We have an email from patron Lauren from Texas. She says, "Hi, Dr. Kirk. I often hear people saying things like, 'I'm not their therapist,' when they are talking about their partner, and I'm wondering what your thoughts are. I understand that couples are in a two-sided relationship, whereas a therapeutic relationship is one-sided and only meant to help the client. However, where is the line between couples taking care of each other emotionally and something unhealthy and one-sided? Thanks for all you do. End of email. Yeah, that's a good question. And on one hand, if someone said I'm not their therapist, I could get on board with it. And the other hand, I could see situations where I would not. On the situations where I could get on board with it, it's when you have a couple and you have an underfunctioner, and that underfunctioner is relying too much on the other partner. And the underfunctioner is it's not reciprocal, right? Overall, the underfunctioner is a drain on their partner, you just can fill in the blanks in terms of details. So in that situation, and I've literally said that myself, I've not in my marriage, but in other relationships, other sorts of relationships, I'm like, look, I'm not their therapist. Or you've actually heard me say things like, when I have a relationship that is abusive and someone's abusing me, I understand that, and sometimes I know exactly where their behavior comes from. I know their history. I know their relational traumas. I know why they are abusing me. And I have compassion for that and I care about that. But I'm not their therapist. So I'm not going to just stand by and let them abuse me, right? In fact, I might completely get rid of them. That's a funny way to put it. But I'll distance myself from them. I will try to get away from them. And I even know that by doing that, I might be adding to their relational traumas, which will make them perhaps more likely to abuse people in the future. I don't know, but I'm not their therapist. And I'm not going to sacrifice myself entirely in this relationship just so that they can get help. If they want help, they can go to a fucking therapist, right? So in some situations, saying I'm not their therapist is a very important thing to say and think. But there are other times when I think you're talking about, which is you have a couple and both people have relational traumas, as we all do, that get triggered and get acted out in the relationship. And you might be asking your partner, you might be like, hey, I just wanted to talk about the fight we had last night, and I wanted to talk about it, and also I just wanted to explain like why I got triggered last night. It's because my mom treated me this way and that. And then your partner says, look, I'm not your therapist. In that situation, that is someone that is acting in an unfair way, because probably because they're afraid of the conversation, or they feel like they're supposed to cure you, or they're just angry at you and they just don't want to talk to you, or so, I don't know. But in that situation, the way I laid it out briefly, in general, I would say that the person saying, I'm not your therapist, they're just avoiding. All right, this next email is from anonymous annual patron from California. She says, how do I find a couples therapist for an abusive relationship? Since you are one of the only psychologists I've heard say that couple therapy is appropriate for abusive relationships, could you please tell me how to find a therapist willing to work with an abusive relationship? It is demoralizing to call therapists over and over and be rejected because of abuse. End of email. Well, two things. One, I'm not a psychologist. I'm a marriage and family therapist. I'm trained as a psychologist and could be a licensed psychologist, but have chosen not to for a variety of reasons. The other thing is that you say that you've heard that I say that couple therapy is appropriate for abusive relationships. That's not the way I would frame it, and I hope I didn't say it like that. What I would say is it's not inherently inappropriate, meaning that there are some couples that one person is being abusive or they're both being abusive, in which couple therapy can help. And I always feel like I have to reiterate exactly why I say this, because I get a lot of gasps from therapists. So let me explain. So let's say a couple comes into my office, and there's a wide variety of presentations, but this is just one of them. And the couple, over time, I start to assess that, let's say the husband is verbally overpowering. And then let's say I decide to meet individually with each person, and I ask the wife, and she tells me, yeah, he will lecture me for 2 hours. He kind of scares me with how angry he gets, and I get shut down, and sometimes he'll call me names. He'll get really worked up, and it hurts my feelings, and I don't feel safe. Okay. So in this presentation, it's a particular kind of abuse and shouldn't be downplayed. It's severe, but it's not physical, right? And so there's not a physical safety issue, or at least it doesn't appear that it's likely that the abusive partner is going to throw their partner down the stairs, because there's not a pattern of that kind of behavior. And if there was, it would be a different presentation and I would react differently to it. So in this scenario, and let's say I have a conceptualization of the husband as having relational traumas that lead to them having distortions and triggering that lead to the abusive behavior. And then I go to the husband, and it might take me a few sessions, it might take me just one session, but I introduce at least the idea of abuse. I might even use the word abuse, and I've done this before. And I believe that he will work with me on this. And so I talk with him about his abusive behavior and how I understand where it comes from, but it needs to stop. And it's a learned behavior, probably from their parents or something like that. And I get that in the moment it feels justified, but it is not. It is 100% not justified. And I know that's going to be painful to hear and it'll be painful to acknowledge, but I'm here to help. And if you're here to work on your relationship with your wife, then you will endeavor to change this, and you will work with me and your wife so that you can communicate in a different way, in a non-abusive way. Okay, so I'm condensing a lot of conversations into a little bit of time, but if I believe that I can do that successfully, then that is the course that I will take. Now, what people will say from the outside is abusive relationships should never be in couple therapy. And if I presented this case, and I've had cases like this before, and I say, so you're telling me that as soon as I figured out, let's say we're 10, 15 sessions into the couple therapy relationship, maybe longer, and I figure out that the wife is being verbally abused, emotionally abused, I need to immediately terminate with them and refer them to individual therapy. So let's play that out. So I talk to them immediately in the next session, and I say, so I have observed some concerning behaviors in this relationship that tell me that there's abuse happening. And maybe I'd even identify it. I was just like, there are signs that you, husband, are abusing your wife verbally. And thus, it is inappropriate for me to continue couple therapy. And so I'm going to refer you, wife, to an individual therapist to work on recovering from the abuse and drawing boundaries. And you, husband, I'm going to refer you to an intimate partner violence program or an abusive partner treatment program. And I need you to do that. Okay. So if I did that, would that be wrong? No, it could be very helpful if they complied. But abusive people are not likely to do that. In my experience, they almost never do it. They almost never comply with that recommendation. And there's no court order to do so. And there probably won't be, because that kind of abuse doesn't typically get the individual some sort of criminal status, some sort of convicted situation. So what would happen? Well, what would happen, and I've seen this happen many times, is that the wife will go to individual therapy maybe, and the husband will never go to therapy again because he doesn't want to be talked to like that, because it's very triggering to him, because his relational traumas are being triggered in that moment, right? Rejection, judgment, criticism, blame. And the wife sometimes will also never go to therapy again, because if let's say she even indulges and she goes to 5 sessions, well, she's sitting there talking to an individual therapist and she's like, well, yeah, I mean, it's great that you're supporting me, but my real problem is someone needs to change my husband. And since the couple therapist rejected us and my husband refuses to go to the intimate partner violence program, then I don't know why I'm in therapy. So the whole thing will fall apart. Whereas if I do the first scenario, where I actually engage with them, I can actually fix the problem, and I have before. Now, if I thought that he would engage in an intimate partner violence program, and I like, let's say he's very interested in therapy and he's done it before, then I might be more likely to refer them out. But at the very least, what I would do is I would say, husband, I need you to do this thing. We'll keep couple therapy together. Okay. So why are they so terrified? Why is this panic about couples going to therapy when there's abuse in the relationship? Because there are cases, and there is research demonstrating this, that when you continue in couple therapy, the victim will be encouraged to report and complain about the abusive partner, all right? And what can happen and has happened is the abusive partner will go home and use that information to abuse the victim even further, maybe even kill the victim. And that's happened. So because of those cases, there's this panic that just says, never do couple therapy when you have abuse in the relationship. And you don't find a lot of people will provide the other point of view. Everyone just accepts that as dogma. Whenever you hear anything that's supposed to be dogma, like it's always supposed to be this way in therapy, you should be highly skeptical, unless it's something like you should never have sex with your client, past, present, or future. That is an absolute. But the other things, it's not so much, when you hear say, you should never accept a gift from a client, that's not true. That is not true according to evidence. Even ethical experts will not say you should never accept a gift from a client. There are situations where you might actually do your client better by actually accepting a gift, a small gift, this kind of thing, or a gift that they drew a picture for you or something. So these kinds of absolutist notions we should be skeptical of. And this absolutist notion that in all situations, if there's any kind of abuse in a couple, they should never be in couple therapy. That's ridiculous. Now, there are situations that I've been in where I would not do couple therapy. I've had clients where I can't remember a couple that was like this, but let's say that, I did in the distant past have a family where under circumstances where there wasn't any abuse, and so it's hard for me to remember the details, but my vague memory was that the parents were abusing each other. It was mutually abusive. And for those people who think that there is no such thing as mutual abuse, there is. And it's nuanced, and it's hard to tell, because how do you tell the difference between defensive violence and mutual abuse? But to me, once you get into it, and especially if you can get a clear, honest recall from the individuals in question, you can tell the difference between a defensive violent act by a victim versus an abusive act. And sometimes it's more of like a 30-70 sort of thing where one person is... Anyway, point is I seem to remember there was violence going both ways in the couple. And it was extreme. Like there was choking, and it was chaotic, and there was barring of doors, meaning that one member of the couple was not letting someone leave the room, and then they got in an altercation and things were broken in the house, and it was pretty severe. And so I remember in that situation, I did not recommend couple therapy. In fact, my main focus was to help who I believe to be the main victim. Now that I remember, I must have identified one of them as being the main victim. So I remember I went down a road of connecting that individual, the person I saw as the main victim, with an advocate, a domestic violence advocate, and it was and I shepherded that relationship so I could help the victim get out of the house. And anyway, point is like there are situations where it would be inappropriate, because of not only the reason that if I engage in couple therapy and nothing else, at the very least, the abuse would be very likely to continue, but it would also be an opportunity for the abuser to be triggered and thus cause more violence. I think another reason why people will be so dogmatic about this is that they have a false notion that couple therapy is about being neutral, that couple therapists just agree with both sides and never confront one person over the other. And that is a gross misunderstanding and simplification of what couple therapy is. There are times, for example, with abuse, that I will absolutely, quote unquote, take sides. I'm not taking sides, but I am calling it like it is. And I'm saying, hey, you are being abusive and you need to stop that. And your partner has nothing to do with what you are doing. Or if someone cheated on someone, I do not consider that a systemic issue. I do not blame the victim of the cheating. I do not say, well, everyone needs to work on things. No, the cheater cheated and needs to stop. They took thousands of actions to go down a road that they knew was going to harm their partner, and they did it anyway. Now, there are reasons for that. There are reasons for abuse. There are reasons for cheating that we can work on, but those individuals are still responsible for their behavior. Bottom line. So I think that's another reason why people are dogmatic, because they're like, well, you don't want to send it to a couples therapist because a couple therapist will just, validate the abuser. And it's just like that. It's not the case. Now, can that happen? Are there some bad couple therapists out there that will do that? Yeah, sure. Now, to finally get to your question, you're saying that how do I find a couple therapist that will take us, even though there's abuse in the relationship? And the answer is, I don't know. I mean, there's a chance that if you looked for 10 years in your area for a therapist that would take you, there's a chance you could literally not find a single one that had an opening spot. So I don't know, but you don't need couple therapy necessarily, right? If you're really trying to change the relationship, well, one thing you could do is if your I'm assuming that your partner is the abusive one. I don't know, but let's just say that that's the case. If your partner is willing to go to couple therapy, then maybe they're willing to go to individual therapy. And so I think you'd find a greater chance of a couple therapist taking you on if they knew that the abusive individual was in individual therapy, especially if that individual therapy was working on the abuse. So I don't know, maybe that's a strategy. All right, this next email is from patron Kieran from England. She says, would you liken the therapeutic relationship to a foster parent? Because the therapist is like a foster home that is rehabilitating the client or child to a healthy adult and environment, and helping heal past abuse by being consistent and safe, setting new boundaries, and relating more compassionately to the client or child in foster care than their previous life. Yeah, the answer is, I suppose, for sure, that is an analogy, but I don't usually think about it that way. But yeah, sure, that's a way to look at it. All right, let's take a break. We get back, more emails. All right, we're back from the break. Let's do an OPP. These people became patrons in 2020 and have stayed patrons, loyal patrons ever since. We have annual upper tier patron Kyung from Chicago, annual upper tier patron Nard from Vancouver, BC. We have patron Jasmine from Anchorage, Alaska. We have Paris from Arlington, Virginia. Megan from Aurora, Colorado. We have Lisa from Austin, Texas. Jenna from Brooklyn, New York. We got Dan also from Brooklyn. We have Liz from Buffalo, New York. We have Natalie from Switzerland. We have Aaron from Chicago, also Chicago. Another Chicago person, Clayton from Chicago. Diana from Cincinnati. We have Selena from New York State, and Jess from Covington, Kentucky. Thank you for being a patron and staying a patron through thick and thin. Thank you so much. All right, this next email is from anonymous patron. They say, I experienced an emergency level 7 months long manic episode last year. During the time leading up to it, I was in contact with my therapist. She knew what was going on, and I was extremely volatile. I was in an extremely volatile environment and situation. During a moment of crisis, I repeatedly tried to get in touch with her by calling her, but she never called me back. I was emergency hospitalized the next day. Her failure to communicate led to me erratically going through my contacts, calling and texting friends instead. I had to send out multiple apologies later down the road to my friends, which still feels so humiliating. I don't want her to be in trouble, but it does feel like she majorly let me down. She also never checked on me when I missed my next appointment. I went on to be hospitalized 2 more times before finally getting the mania contained. It goes without saying I ended up finding a new therapist after this happened. Anyway, am I wrong to think that a therapist has a responsibility to be there during an emergency, or at least check on an at-risk client? What is the standard when it comes to this? End of email. Well, it's a good question, and I'm sorry you went through that. It sounds really, really, really awful. It's just so awful to go through a manic episode like that and to not have the support that you need. The thing I'll say is that the standard is that therapists need to take reasonable actions to address this issue. Now, for me, for example, if I had a manic client who I was working with and I knew that their symptoms were escalating, I would actually tell the client that I needed to pass this off to someone else. I would still be their therapist, but I am not set up to be a therapist that is on call or a therapist that can help in situations like that. I don't have the resources and I don't have the desire as a professional to do that kind of work. I did in the beginning of my career, but not anymore. And so I would say, I'll be here for your sessions when you come, but I'm not going to be there in between sessions. And if you text me and you're an emergency, you need to call the crisis line or 911. I'm not going to be an on-call therapist. Okay. So I disclose that to clients in situations like this, and therapists need to be clear about this. A more common situation is, say, if you had a client who was thinking about suicide and was having an increase in thinking about it, the therapist needs to be very clear as to what their role will be in between sessions. Because it's rational for a client who has an increase in thinking about suicide to reach out to the therapist for help, right? But if you're the sort of therapist that doesn't want to provide that kind of service, then you don't. Now, if you do want to provide that kind of service, you might charge for it, right? You might even charge extra for the main sessions as a way of making up for that extra time that you're even just being available. Because in order to be available, you need to be sober the entire time. You need to be available. You need to check your phone 24/7. It's a thing. So, and I don't recommend that therapists do this, because if you're in private practice, it's really hard to have that level of responsiveness. So I don't know what your therapist told you. It sounds like your therapist might not have said anything to you and just reacted to the situation, which is not the standard. That is not what you should be doing. If you give the impression, or you leave it open to interpretation, and a client going through a crisis has enough reasons to believe or not enough reasons to disbelieve that you are available 24/7, especially in a crisis like that, then that's irresponsible as a therapist. You just need to be clear. So I don't know what the situation is, but I would also say that most therapists, at least anecdotally for me, are not going to be available in a situation like that. If they're in private practice, they have other clients, they have their social life, their own private life, and they wouldn't have the capacity to deal with that. What are they supposed to do? Just drop everything and drive to your house, or what? You know what I mean? It's not a viable situation. Whereas if you have an on-call therapist that is trained to do that knows what they're doing and charges and has all the appropriate disclosures, then maybe they can do that. Now, there are different degrees to this, that you could be, for example, kind of on call. Like if it's a major crisis, you might be available by phone for 15 minutes, but you're not going to drive out to the house, or you're not going to handhold the client as in a good way. Handholding isn't necessarily a bad thing, but you're not going to escort or help the client go to a hospital or whatever. So there's different degrees to this, but it sounds like your therapist at the very least left the impression that they might be available. And so when you reached out to them and they weren't available, then yeah, that's an irresponsible act. All right, this next email is from anonymous patron. She says, "Hi, Dr. Kirk. I recently got back into therapy after trying a couple out and not liking them very much. With this new therapist, I'm only 3 sessions in, but I feel like my therapist talks way too much. She talks over me, and she self-discloses more than she asks about my situation. Today, I was explaining to her about my relationship, and before I finished giving her a full history and dynamic of our relationship, she says that she thinks that he is grooming me. My partner is grooming me. I don't believe this is the case at all, given the many years we've been together. Regardless, I felt it was irresponsible of her to come to such a conclusion based on how little I spoke to her about my boyfriend. She then went on a rant about her own relationship that took up most of the session. What are your thoughts on this?" End of email. Well, my thoughts is that this therapist sounds like, at the very least, a bad fit for you, and at worst, a terrible, terrible, terrible therapist. Like, I can never know that these descriptions are accurate, but if this is anything close to accurate as to what happened in this session, yeah, I have no idea what this therapist is doing. I have no idea how they even have a practice. So I would probably look for a different therapist, and I'm sorry that you went through that. Again, I can't know that. Your description could be distorted. If the therapist were here, they could maybe defend themselves and say, no, that's not what was happening. There's a lot of things that could have been happening that could explain this kind of, like one scenario, and I'm guessing this is not the case, but who knows, is that anonymous patron, you yourself might have misinterpreted the grooming thing. I'm guessing that wasn't the case, but that could be. Another thing is that anonymous patron, you might have been not talking very much, and the therapist thought, well, maybe if she talked a lot, it would help you to feel more comfortable, and so she just started talking about her own life as a way of trying to prompt you to talk. Again, it doesn't sound like that, but I can't know. But based on your description, yeah, huge yikes. Let's see, you've only had 3 sessions. She talks way too much. She talks over you. I mean, yikes. She self-discloses more than she asks you about your situation. So would you tally all the conversation that you have in a session according to you, she's talking about her own life more than you're talking about your life. And my God. And then she says that your boyfriend is grooming you based on very little information. And you're like, no, he's not. And even just the term grooming is a red flag of someone that doesn't know what they're talking about. The term grooming is a well understood clinical concept that has been in the literature for, I don't know, I'm guessing decades, probably 50 years-ish, I'm just guessing, but long time. So it's a phenomenon. Abusers will groom, and it's important to recognize the signs and help people to get out of those relationships. However, in today's internet milieu, you have a lot of people, including fucking therapists, that are throwing around the word grooming for extremely dubious scenarios where someone is, it's like gaslighting. People will just throw around this term when they just don't like a situation or they're interpreting it in a certain way. And they just say like, oh, he's grooming you. Oh, he's a gaslighter. Oh, he's a malignant narcissist. And you're just like, my God, people. Lay people, fine. They don't know what they're talking about. But clinicians, come on. All right, this next email is from an anonymous patron. She says, hi, Dr. Honda. I'm entering my second year in a clinical psychology PhD program, which is when students start seeing clients. I was feeling anxious about this because we have only taken one class in psychotherapy where we briefly went over therapy techniques and did 3 practice demonstrations. I did not get to shadow. I did not get to observe. I did not get to watch a tape from other students. And despite all this, I was the only student assigned a client. I do not feel trained or well prepared to start giving therapy. I feel like I'm going in blind, and I feel angry and disappointed at my program. Is this a normal experience? End of email. Is this a normal experience? Well, maybe, unfortunately. So there's 2 things I'll say. One is that it's possible that your program has, like in my university, there are 2 different models for when someone would start to see clients. The model that we follow in my program, or at least the way it used to be, I'm not up to date on things at Antioch anymore, but the way that we did it was we waited a long time before we had students actually seeing clients. There were a lot of prerequisites and a lot of courses and a fair amount of time that the student needed to spend before they actually saw their very first client. Now, what I'll say also to that is clients, or the trainees, the students, they always felt inadequate and they never felt ready to see a client. They were always terrified. So, and some students would be like, I don't feel ready. Maybe I should wait another quarter. And I'm like, you'll never feel ready. You could be in school 10 years and you still won't feel ready. There's no amount of education that we can give you that will make you feel ready to do it. You just have to do it. And then eventually you'll realize that it's not as scary as you're making it out to be. And you have more support around you than it feels like you do. Anyway, so there's that. So that was our model. But there were other programs at my university that had a different model of training where you would actually start seeing clients fairly early at a limited capacity. Sometimes we called it like a pre-internship practicum, that kind of thing. So the regular internship was, far into the program when you had a lot of classes under your belt. But there was this other thing where you would see maybe just a handful of clients, maybe even just like 1 or 2 clients at a time. And you would start seeing clients very early in the program, maybe even after you only took 1 class on psychotherapy. So in those situations, what needs to happen is those students need to be limited in terms of how many clients they see, and they need to be heavily supported. They need people to be there right away because we can't depend on their education level to allow them to be very independent, right? They need to be overseen very heavily. Now, interns later on in the program also need to be overseen, but to a lesser extent, right? They still need to be very much monitored, but to a lesser extent. So I don't know if your program is like that, where they start very slow with just a few clients and you're just experiencing that normal jitters that every student has when they start seeing a client. I don't know. The other possibility is that the program doesn't know what they're doing and they are just throwing students to the wolves without taking proper precautions or without having enough support for you. I suspect it's kind of in that direction based on your email, because like I could see a scenario where the program is actually doing the right things, but you and your supervisor don't have a very good relationship or something, or your supervisor is overstressed or something. But I'm going to take a guess and say that if you had a supervisor that was there for you and you felt safe and securely attached to, and that supervisor knew you well, that you probably wouldn't have emailed me, is my guess. So I don't know. It's hard for me to tell. But yeah, there are programs that will have extremely low levels of education and guidance regarding how to be a therapist, even by the time you graduate. I won't get into specifics, but there are programs I've heard from graduates from programs where they've told me that they graduated with basically almost no education on how to be a therapist. And some of these people have even come to me, and this is back in the day when I still offered private supervision, and they would hear about me, or they would know me as a professor, and they would say, I need you to make up for the education that I never got in my program. I mean, my program in theory educated me, but I feel like I didn't learn anything. And so I need you to start from the beginning and teach me everything that I need to know. And so I would do that with students. And, it's unfortunate. It's a disservice to the students, obviously, because they're spending upwards of $50,000, $60,000, $100,000 and years of their time on the program. But it's also a massive disservice to the clients involved. I mean, imagine being a client and you're like, is my therapist even trained at all? I mean, they have a master's degree, they have a doctorate degree, but you just think that should mean something, but it doesn't always mean something. All right, this next email is kind of along those lines. Patron Deborah, she writes, I just wanted some suggestions as to how to decide which type of therapy to use in my practice, since there are so many. There are so many different types of therapy, and I am confused as to which focus to be certified in. Just chime in here. Yeah, well, the thing that I say with students is just pick one and know that it's just the first one you picked. But I recommend eventually learning all of them, or at least 5 of the major ones. The 5 major umbrellas that you would really want to absorb. And these are not just things you learn, they're paradigms that you absorb. And the ones that I would recommend are the cognitive area, and I guess you could say behavioral area is near there. But you definitely want to understand cognitive therapy. You definitely want to understand behavioral therapy. You definitely want to understand the basics of humanistic psychotherapy, not just the surface level Rogerian thing that you'll get in graduate school, like active listening. And that's good, but you want to understand humanistic therapy, here and now, existential therapy. You want to understand within humanistic therapy, phenomenological listening, getting in touch with yourself and emotions, pushing back on cultural indoctrination, this kind of stuff. You also want to understand as well as you can within your lifetime how culture affects people and affects their narrative of the self and the meanings in their life, and how it can oppress and internalize oppression, and how that works out with people in a variety of different domains. You also, I think, need to know about systems theory. And again, knowing the premise of systems theory is one thing, but actually understanding it is a completely different thing. It takes a long time. You should also understand attachment theory and psychodynamic theory, how the past, how relationships in the past affect in the present, that kind of stuff. I think those are the major areas that I would recommend. And you're not going to know all those things, You're not going to know all those things in the beginning. So I recommend just picking one and getting to know it as much as possible. And then when you feel ready, start incorporating another umbrella to your path of learning. Oh, actually, another umbrella that I'm leaving off is brief therapies and collaborative therapies, solution focus, narrative, this sort of stuff. These are powerful ideas. And again, it's not just a technique. It is a paradigm. It's a philosophy. It is a way of thinking, a way of seeing the world that once you get, really helps occasionally in therapy. Going on here, do I have to be certified in each of them to use them with my clients? Just chime in here. No, I don't have a single certification in anything. I heard you say that with trauma therapy that you need training and supervision. End of email. Yeah. So with trauma therapy, you would how do you become competent enough in my book to actually treat someone with trauma? Well, you have to work with either a professor, a set of professors, an organization, a supervisor that really gets it. And that's how it was for me. I was taught about trauma throughout my career, but it wasn't until I actually had a mentor about, 10 years into my career that walked me through all the research and the therapies and how to interpret dissociation, how to interpret trauma, how to do it ground level. Because I, before that point, would have said, yeah, I specialize in trauma, or I know enough about trauma, I know enough about PTSD to treatment, but I didn't really. And it's so complicated, and there's so many nuances that you have to learn, and so many exceptions to the rules, and so many different presentations that you have to experience yourself. If I just describe to you, if you don't have PTSD, or you don't know anyone who has PTSD, when I describe PTSD to you, you won't know really what it is. You'd have to see it firsthand, maybe even experience it yourself to really get it, to really understand everything involved in it, right? So that's what I mean. I could go on and on about how to become, and that's just trauma therapy, right? So, but that general guideline that I laid out for trauma therapy probably applies to every single area. To become actually competent in brief therapies is the same. You have to have a mentor or a group of professors that really know how to get you to challenge your paradigm and get you out of a certain way of thinking and into the brief therapy way of thinking. It's really hard, and it's complicated, and there's a lot of nuances, and you have to practice it and iterate on your knowledge and go back to your mentors and say, this happened. And they're like, ooh, that's interesting. Let's look there. Let's talk about this. And you need to read the research, and you need to see how it works in therapy when it it's experience with education. So even just becoming certified in something isn't, in my book, enough to be competent. If I met someone that was certified in exposure therapy, I would know that they probably had the baseline education, which is great, but by no means would I just be like, yeah, they're fully able just by that detail to treat everyone with trauma. That's not necessarily true. It's complicated, To become a therapist, it's a lifelong journey, and it's an active journey. You have to participate in cobbling together your own educational program. When you're in graduate school, you don't have to do that. They just walk you through the courses and they tell you what you need to know. But beyond that, you got to take it by the reins, and you got to make it your own. And you have to get out there and read the books and find those mentors, find those supervisors, find those people, those colleagues. That's like to become competent in trauma therapy. You could just have a colleague that knows everything about it, and they just, they don't mentor you, but they teach you everything and they help you with it, right? So that's what I would recommend. And that's why it's so important that when you're in graduate school that you network a lot, that not only for colleagues to eventually stay in contact with after graduation, but also with professors and other sorts of people that are connected with your program. Because if you connect with them, then they can be lifelong a part of your education and growth. All right, well, that does it for that set of emails that related to therapy and training and that sort of thing. Let me know what you think. Email in if you want. Comment below if you want. And everyone, please take care of yourself because you deserve it. You really, really do.